All right, well, welcome everyone. I decided to pick a couple of the highlights from some of the recent meetings and kind of touch on some general mini topics and kind of delve very superficially into them to hopefully give a little bit more information. So I'm not going to be necessarily quite as in depth on a single topic, but hopefully touch on some highlights from the meetings and some interesting things that may be on the horizon. To start with, there were a couple talks about imaging and as it pertains to specifically thoracic limb lameness. I find that in my day-to-day, I'm sure many of you do too, thoracic limb lameness is probably one of the more frustrating types of lamenesses we see. Certainly we can do x-rays, we can do our exam and kind of get some general ideas, but beyond that, especially as more often than not the x-rays may be normal, it becomes really hard to really determine what the specific cause of the lameness is and therefore what to do about it. A lot of times I just say, well, let's just try some physical therapy, see what happens, and hope that maybe it gets a little worse so I can really tell what's going on. Elbows can be maybe a little bit easier. A lot of times we're dealing with more obvious arthritic conditions or trauma, things like that. But shoulders especially can be more difficult to interpret. Kind of just a review briefly of kind of some of the things we worry about: shoulder pathology, bicipital tenosynovitis, supraspinatus tendinosis, medial shoulder instability. Again, x-rays can be helpful certainly with the juvenile conditions. We see an OC lesion on the caudal medial humeral head, neoplasia, trauma. But again, we get into those soft tissue issues that can be a little bit more difficult. Ultrasound can definitely be helpful for looking at supraspinatus or infraspinatus muscles. The biceps tendon is something I often will call the radiologist in for to look at, even sometimes the caudal shoulder area. But the ultrasound can certainly be user dependent. It's susceptible to artifact and doesn't always give you the whole picture. Arthroscopy, certainly we do arthroscopy, but again, we're really just looking at inside the joint, and there are certainly other issues, a lot of them, that we are concerned with outside the joint, so it's not going to give us that picture. CT certainly provides a three-dimensional evaluation of the skeletal structures, but it certainly is limited in soft tissue contrast resolution. There's some looking at, we don't typically do contrast arthrography with radiographs these days, but CT arthrography may be something to be considered. MRI provides kind of a very good multiplanar imaging acquisition. It gives us a lot better soft tissue contrast, so we can look at the cartilage, the joint capsule, and then the supporting ligaments and tendons and muscles where we may see our primary issues. We do need to have specific coils associated with that. So the MRI we actually have here is not set up to do musculoskeletal. It's obviously we do a lot of neurologic MRIs, but we're really not set up to do musculoskeletals. And certain parameters that we manipulate can be difficult to know, and also with our smaller animal patients, some of these more subtle lesions can be a little bit more difficult to pick up. So one abstract from Colorado State was talking about PET scans, or positron emission tomography, for evaluation of canine lameness. So they're looking at kind of what they're looking at, and is this something that might be useful in the future. They had 23 dogs that had a visible lameness with no definitive cause. This was front or back leg, but they excluded the obvious things, the cruciates, the OCD lesions, something basically we're not really sure why this dog is lame. And then they did this emission tomography, which has become a growing diagnostic in people. Basically their protocol was they walked the dogs for 15 minutes, then they anesthetized them. They gave the injection of the radionucleotide, which we'll talk about in a second. They waited 40 minutes and they did a regular CT scan. Then 20 minutes later did the PET scan, which basically about an hour after the injection, and then immediately did a contrast CT. So basically with all those kind of images put together, we're able to get a big picture. The CT scan, just a little bit kind of in depth about what a PET scan is. A CT scan, again, has the high spatial resolution, but we're really looking for bony structure. The PET imaging is actually looking at the function. So it's really, they inject this radionucleotide and it gets absorbed by the cells, and so it actually results in a quantifiable imaging of glucose metabolism. So we're looking at areas where metabolism may be upregulated. They use it a lot in cancer studies, which stands to reason. But Colorado's been looking at, what about musculoskeletal injuries where we may also have some of that similar trauma. The radiolabel tracers, the 18FDG or FLT will look at these cells. And with the musculoskeletal issue, we're really looking at the uptake due to physiologic glycolysis secondary to injury or repair. Whereas with cancer, they're really looking at unregulated increase in glucose transporters. So the idea, though, that this metabolism should be increased. When we do contrast enhanced on a CT, we also can find some more soft tissue resolution, but really there we're looking at kind of neovascularization, vascular permeability changes. Is this contrast kind of leaking out into the periphery? So maybe a little bit less specific. So what I've been able to find is they're at UC Davis and at Colorado State, they're starting to use it, looking at horses, looking at the musculoskeletal, looking at small animals, even questions of whether it might have some sports medicine applications in their performances and how they're working. To just kind of show you, this is a slide from a person. Look, again, the cancer has certainly been the most common. You see just this the CT without contrast. You can see a little area there where there's a decrease in density, which is suspicious for maybe a metastasis. And then with this PET scan, and I'm not a radiologist, I'm not going to get into all the little different permutations of how they come up with these images, but you can obviously see they're a lot more obvious with the PET scan. And again, the combination of the two can potentially be beneficial in really isolating some of these areas. So in terms of this, I apologize, it came out a little blurry. So the group at Colorado did a dog that had a forelimb lameness that they couldn't identify. And with the permutation with the PET scan, they saw these areas here and so on one leg but not the other, that was in the region of the flexor carpi ulnaris muscle. And they actually, with this information, they then went back and did an ultrasound and were able to determine that the dog had a slight tear in that muscle. So it gave a little bit more detailed information. And to summarize the study that came out of there, that was a specific case study. They had 6 dogs that had soft tissue injuries that had appropriate PET findings, and of those 6, only 4 of them, not all of those 6, had signs on CT. So if they'd done the CT, they would have missed it if they hadn't done the PET scan. And conversely, they diagnosed osteoarthrosis in 8 dogs by the CT scan, and only 75% of those had signs on the PET scan. So again, if they had just done the CT, or if they had just done the PET scan, they might have missed some of the arthritic changes that they found on the CT. So their conclusion is that using both of them will help maybe kind of give a better, bigger picture to help isolate the issues that's going on. And again, in this dog, they found the flexor carpi ulnaris. They followed up with the ultrasound, and they initially did conservative management for several weeks and re-ultrasounded, and there was still some abnormalities, so they injected platelet-rich plasma directly into the area and got some improvements. But ultimately, they are recommending the combination of the PET CT to increase the specificity of the PET findings and provide specific imaging diagnoses. Now, I looked into where are they really offering this besides outside of this university, and of course, if you Google PET, you're not going to find exactly what you want. You're going to find a lot of veterinary clinics, but nothing about the PET CT. So at this point, it appears that that's still kind of in the study setting, but it certainly seems like it could be interesting technology to add into how much you have to modify your current CT scenario to be able to add in this diagnostic may be helpful and really help hone in on some of these lamenesses that are difficult to interpret. Next, talking about chronic pain management, and this is kind of a little bit of obviously a very wide subject, and trying to pick a couple different abstracts that may alter how we're thinking about some of this management. Obviously, it's a pretty common, prevalent issue that we have to deal with. NSAIDs, we certainly have been, and more specifically looking at arthritis. NSAIDs have been the mainstay, but obviously we can't give them in all of our patients. And we certainly, in veterinary medicine, certainly in our clinic, have been using Tramadol, like crazy. And there's recent studies, and maybe not even so recent, that really are saying, how does Tramadol work? Is it really working? Is this the best patient or medication for some of these patients? So briefly to review, Tramadol, it's a weak mu agonist, which is about 1/10 of the potency of morphine. Its metabolite is more potent than the parent compound, and dogs metabolize it more rapidly to a greater extent than people, and may eliminate it more rapidly as well. So how long it sticks around is a little questionable. Tramadol also has serotonin and norepinephrine reuptake inhibitor roles as well. It's only fairly well absorbed after oral administration, 30% immediate release and 10% extended release in dogs. And really there are actually fairly limited clinical trials that prove that it has good anti-nociceptive effects in small animal patients. But we use it. It's fairly safe. Obviously with it becoming controlled, it's become a little bit more difficult or a little more hoops to go through, but the accepted dose for arthritis is about 4 to 5 mg per kg every 8 to 12 hours. So, especially in a larger dogs, that ends up being a lot of Tramadol tablets that we're dispensing over a long period of time. So Dr. Budsberg at the University of Georgia, I did a fellowship with him. He looked at kind of a more objective look at Tramadol and its efficacy on pain and dysfunction in chronic OA joints in dogs. It was a blinded prospective trial, clinical trial, and so they had 35 dogs that had arthritis in at least one elbow or one stifle. They eliminated dogs that had, again, instability issues. Really we're just dealing with chronic arthritis. And this was a crossover study, so every dog, each of these 35 dogs, actually got all 3 treatments, which were the placebo, Carprofen, or Tramadol. They did a 7-day washout in between each period of time, and each dog basically got, they had them all formulated, so they were just little capsules. So the owners didn't know what they were giving, but it would have been one of the 3 of these, and each dog, like I said, got each of them. And then Dr. Budsberg is big on the force plate, so he actually measures ground reaction forces, including the peak vertical force and the vertical impulse. And so just a little review of the force plate analysis. Basically, when the dog strikes down on the force plate into the stance phase of the gait, this is kind of the whole stance phase from putting the foot down to pulling it up. That's the impulse under this bell. The peak vertical force is what it sounds like, that's the most force that's exerted during that stance phase. So it can give us a very objective measure of how are they actually using that leg. And there's certainly been controversies, how accurate is this? I worked with him and we did a lot of research dogs, and getting dogs to walk normally and plant perfectly on that force plate sometimes can be a little difficult. But in general, I think it's one of the best ways we have of getting that objective information versus just owner questionnaires and our exams and things like that. And basically what he found was that there really wasn't a significant difference in either the peak vertical force or this vertical impulse during the placebo or Tramadol treatments relative to what they were when they first entered the study. With the Carprofen, there definitely was improvement in their function. So, this is a suggestion that really maybe Tramadol is not doing as much as we think it might be. Where to go with this? That's a good question, because what are other things that we have? And certainly there are some newer things on the horizon. One thing I felt obligated to touch on, just because it's kind of such a controversial topic, is the cannabidiol oil. And there is a study that looked at, kind of a pilot study, looking at the pharmacokinetic safety. They don't have all the information with this abstract on the CBD oil, and basically this was also a double-blind crossover study, placebo-controlled. They had 11 client-owned dogs with radiographic arthritis. They got CBD oil or placebo oil for 4 weeks. And again, there was a washout period, and then all the dogs got the placebo. So each dog got both treatments. And this was a more subjective assessment of lameness. They had assessment of lameness with the vets and owner questionnaires as well at week 0, 2, and 4. And then they also looked for side effects as well as CBC and chemistry. And just a brief, kind of looking into how are we expecting that this is working? Where are we expecting? The cannabis species contains at least 480 distinct compounds. The phytocannaboids, which are close to 70 of them that are unique to the specific cannabis plant. And these are structurally similar to the icosanoid arachidonic acid compounds, which are the precursor to prostaglandins and leukotrienes, so our inflammatory cascade. And the cannabidiol was the first, I think there's different ways to pronounce it, was the first to be isolated and really studied. In the body, there are endocannabinoid system that have been studied in people, and those have their own receptors, kind of like, the opioids have their own receptors. There is an endocannabinoid system. There are at least 5 that we know of, but these phytocannabinoids that are in the cannabis species do work on these receptors. So that's the thought behind, let's use this because it should have an effect on this pathway. And so it's thought that it will help with pain by modulating inflammatory response as well as tissue and nerve injury. So basically both maybe central effects and local effects. But they've it seems like, and again, this is, I think you could spend a whole lecture talking about this whole topic in and of itself. There's so many different little compounds and different ways that it affects every system. So again, the CBD, I think, is supposed to be kind of the most dealing with this specific pathway that will be potentially helpful with pain. There's also a question, can it be synergistic with the opioids? There's even thoughts that NSAIDs themselves may actually interact with this endocannabinoid system. So it's certainly something that I think is obviously on the forefront of studies and probably will continue to be for a little bit. In this study, they did find a significant decrease in pain and an increase in activity at weeks 2. So in the first couple weeks, it definitely seemed to get an effect. Maybe not as much as time went on. Maybe it was a little more of a blunted effect. So it was really only significant in the activity increase. Visually, there were no visual side effects reported by the owners. But interestingly enough, 8 of those 11 dogs ended up having an increase, a moderate enough increase in alkaline phosphatase by the 4-week period. That's definitely something I think needs to be considered, and certainly some more safety tests and maybe more objective efficacy tests are in order to really determine, is this going to be effective? Because I know you probably had, I don't know how many of you are actually using it in practice, or at least have had clients asking about it, because it's definitely a hot topic right now. And so I think there's still a lot we don't know about it, how it works, and what side effects it may have on liver metabolism. What else do we have? Gabapentin, we have actually started in our clinic using gabapentin a lot more as a postoperative management versus Tramadol, just because the reasons of the amount to have to dispense and how effective is it really not 100% certain about the mechanism of action for gabapentin. It includes binding of calcium channels, influencing glutamate, norepinephrine, and substance P. It's well absorbed following oral administration and eliminated largely unchanged by renal excretion. It has a short elimination half-life. Drug interactions appear to be minimal. One point, the suspensions or solutions that are out there often contain xylitol, so just make sure we're aware of that when dispensing it. And typically we talk about doses about 10 to 20 mg per kg every 8 hours. A little bit longer result in cats, so 5 to 20 mg per kg. There's a pretty wide safety range. Typically we start pretty low, and then we can increase the dose pretty significantly every 6 to 12 hours. But other than, sedation, side effects in general seem to be minimal. And so it seems to be, at this point, kind of an effective, certainly something until we have something that's more specific for arthritis, things like that. I don't know how many of you out there are using Gallorant now. I mean, we don't have it here in the clinic, and so I don't have a good sense of how it works, but certainly it seems to be a growing area. And so this is supposed to be kind of the NSAID basically still kind of affects that general pathway. Brief review with the arachidonic acid pathway. Ultimately, we're talking about creating, and this is where our cyclooxygenase inhibitors work, But the ultimate goal is trying to reduce these inflammatory prostaglandins, realizing that we can have side effects, unwanted side effects, because prostaglandins also play good role, have good roles as well. But the pain and inflammation that are mediated by the prostanoids, especially PGE2, we would like to reduce. And so the Gallorant works more specifically at the level of the prostaglandins. They have 4 receptors. And EP4 is one of the ones that's most commonly associated or is suspected to be associated with a joint inflammation. So the Gallorant is a piprant class, so it's a prostaglandin receptor antagonist, and it specifically, again, targets this EP4, which is the primary mediator of the sensitization of sensory neurons and inflammation caused by the PGE2. So it's considered analgesic and anti-inflammatory. And so the idea being that since it's even the most selective, or getting down into the lower levels of the pathway, its safety profile is thought to be much higher. So another thing, and I don't have a ton of information on this, it was kind of almost an aside in one of the talks, synovine OA, radiosynovie orthesis. Basically, this is a radiolabel colloid that is actually injected intra-articularly, and it targets and kills activated synoviocytes and macrophages that are activated and release the cytokines. So kind of think like I-131. So it's going to target, the idea is in the joint, it's going to have all these activated synoviocytes, and so this nucleotide should target these and eliminate that. Again, it's still kind of in pilot studies. They're looking at elbows specifically. There's a cohort study involving LSU in Missouri. It's kind of an interesting concept, that may be more specific to inflammation or joint inflammation. I think this doesn't have the same issues associated with the radiation fallout that you see with I-131. I think it's more stable, and so I don't think you have to go through quite as many hoops when these animals, if they're injected. And there's even thoughts, if it can be administered into, say, an early cruciate joint, could it actually have effects in altering the course of the cruciate degeneration? So it's kind of an interesting, I think it's still very early in its studies. It's kind of an interesting idea or thought. Ultimately, I think, just kind of summarize in general about the pain management aspect of things, I think, we're finding that Tramadol really may not be as effective as we think it can be, but there are some other alternatives out there. There were a couple talks about gastrointestinal surgery, specifically dehiscence and factors, and we know there's certainly lots of reports, but people are always kind of looking at new information. Is there anything new? Is there anything we can learn? So this was a study out of VCA West LA, factors predicting the incidence of dehiscence following gastrointestinal surgery in dogs and cats. 243 cases, so a pretty large case group. And basically, they had animals that underwent GI surgery. There were 243 cases. Now, I thought it was may make interpretation a little difficult. They lumped everything together, so gastric surgery, intestinal surgery, enterotomies, anastomoses. So, I think obviously there can be maybe some variations in there, but they just kind of generally lumped everything together. And really they were looking at a lot of preoperative factors, the ASA score, the emergency status, whether this is something, let's stabilize the patient overnight and plan to take it to surgery the next day, or do we need to rush in the middle of the night, looking at lactate levels, intraoperative factors, looking at the procedure itself, whether or not there was peritonitis already present. Some of these may have been a second surgery or a follow-up surgery. And postoperative factors, looking at the dehiscence, how many days they stayed in the hospital, and the survival at 2 weeks. At 2 weeks' time, how many of these animals were still alive. Their overall dehiscence rate, again, these are all lumped together, was 5% when they took out just the resection and anastomosis. And I don't think they had as many of those as they had the others. That was actually 11%, so a little higher with the RNA, but I think the numbers, I don't know if that was a significant change because the numbers were not as high. In the animals that did have dehiscence, there was a 30% mortality rate. ASA scores were significantly higher, 3 or higher, in patients that developed dehiscence and peritonitis after surgery, and in patients that didn't survive to discharge. So basically every unit increase in the ASA score increased their risk of dehiscence by 2 to 5% or times. The ASA scores also increased when there was increased lactate at admission, which we know lactate's a measure of tissue necrosis, so that can certainly be makes sense. And then admission lactate levels were significantly higher, 4.6 plus or minus 3.8, in patients that didn't survive 2 weeks, and that's kind of consistent with information we already have out there. Interesting, there was no significant difference in the rate of dehiscence or survival between animals that had emergency or a scheduled surgery. So there was also kind of some review articles review discussion topics talking about this as well. We have a lot of studies out there that show kind of different factors that may result in dehiscence or increase the risk of dehiscence. Inflammatory bowel disease, location of the issue that we're dealing with, the surgery, hypotension during surgery, peritonitis pre-existing. Intestinal foreign bodies previously has been on the side of can increase the risk of dehiscence, but there's also studies actually that show it may have a protective effect. So there's a lot of different ways to review some of this data. Albumin and low plasma proteins, that's been pretty consistent, less than 2.5 mg per mil or deciliter. And so with this previous study that looks at the ASA score, that's probably the ASA and the lactate are some things that we can, objective measures that we can kind of hang our hat a little bit. The lactate, the one that they did not really look at, which the criticalists have actually talked about, is looking at lactate. We have this moment in time where there's actually a question as to whether the clearance of lactate may actually be of a better indicator of prognosis, especially when we're talking to owners. So if they have a high lactate, they make it through surgery, what is their expected prognosis in 2 weeks, looking at these survival times, and maybe getting a second look the next day, how is it back to normal? Is that going to give us a better information to be able to talk to owners about their overall prognosis beyond just how they're subjectively doing clinically? There was also a little review of looking at comparison of dehiscence rates for hand sutured versus stapled anastomoses. They had 29 out of 205 dogs overall that had dehiscence in general. This was 14%. So, the previous study showed a 5% rate of dehiscence. Again, can be variation depending on how we're looking at the numbers. Between the sutured and the stapled, it was not a significant difference in which ones ended up with a dehiscence. The hand suturing certainly was significantly longer surgery time, but the overall incidence of dehiscence was not significantly different. In people, there are actually specific recommendations of whether to staple or suture based on location and the underlying disease. They have actually shown some studies that there's twice as likely to have dehiscence if they have been stapled when they're in an emergency situation. But we use the stapler a lot here, patient size permitting, and have been very happy with how how the surgery goes and how they heal. Just to remind you kind of the surgical stapling, this is the GIA or gastrointestinal anastomosis stapler. And it's a side-to-side anastomosis. So basically we have this is showing a colon, but you do basically two intestinal loops, and you put the anti-mesenteric surfaces together, and then this slips in on either side, and basically it's kind of like a little credit card machine almost. You kind of zip that forward and back, and what it creates is, again, this side to side. So we have like a pair of pants. That's the best way I describe it. So we have a little crotch here, but then we have this side to side, and then using a TA stapler or another GIA stapler, you basically close that together, the belt together. And so now you have just the end to side stapler, and these staggered rows of staples, they're very secure, and again, obviously make the procedure more quick. And so in my view, when I'm dealing with these, especially on a more emergent basis, getting in and out, having being able to shorten my anesthesia time really is a big plus with these staplers. Moving on to wound management. And by wound, wound is a little bit of broad category. There are a couple different types of topics I touch on, considering an incision a wound that we create. So there's been, and I don't know how well it's caught on. We have not been using it here, but the barbed suture, so the unidirectional suture, they have been looking. There have been a couple abstracts at the ACVS meeting and the soft tissue surgery meeting looking at both clinical and in ex vivo use of the barbed sutures. So this abstract comparison of surgical time and complication rate of subcutaneous and skin closure using barbed suture or traditional knotted suture in dogs. So this was a prospective clinical study. They had 34 dogs undergoing TPLO surgery. And so in closing their sub-Q, they did the barbed, or they did a regular suture. They used Maxon. And then they looked at complications at 2 weeks or further follow-up via telecom. So one issue a little bit with this study is that some of this was just them talking on the phone to the owner saying, oh yeah, the incision looks good, but obviously we know how those kind of conversations may reflect the reality. They did find that the use of the suture, the duration of the closure, was not significantly different. And they did find that there were more intraoperative complications in the barbed suture, so maybe it was a little bit more difficult to kind of hang up on things, getting the suture incision closed, but really not a significant difference in a major versus a minor complication. And again, when we talk about postoperative infections, there's always, we'd say there's a lot of papers that talk about postoperative infections that never actually have a culture that truly documents there is an actual infection. And a lot of these we can certainly see some inflammation that may be suspect. There's some studies that looked at the oral cavity in cats. They found that certainly it can result in faster closure, but the healing time is the same. There have been looking at the bladder in cadaveric canines and did not find a difference in strength overall when they tested these. But other looking at, this was actually at the Soft Tissue Society meeting, looking at kind of ex vivo, the comparison of security, biomechanical strength, and watertight nature in canine cadaveric intradermal closure, so back to the skin, using conventional monofilament suture versus unidirectional barbed suture. They had 48 full thickness 4-centimeter wounds in canine cadavers, and they closed the intradermal layer using Maxon with an Aberdeen Knot or unidirectional monoderm barbed suture. I think that's Quill, I think is the name. And then they applied a tensile load perpendicular to the long axis of each incision and measured the load to failure when that incision split open. 12 in that group, or each group, and then a watertight, they had this little jig that they made where they could create this watertight construct and could measure leaked fluid from the incision site over 3 minutes. First of all, I had to remind myself what an Aberdeen Knot was, because I don't do that routinely, but it's pretty straightforward. I don't know how many of you guys use those, but I know it kind of makes for a pretty secure closure with a little less suture material. Basically what they found was the monofilament, the regular Maxon, had a higher maximum load at failure. So it was stronger than the barbed suture at failure, and that was significant. But the barbed suture was better at the leak test. So the mean wound leakage was significantly greater with the monofilament group. Now, of course, this is a ex vivo study, so how this relates to clinical application. Does that mean that if we use the barbed suture, if it's not going to leak out, are we less worried about infection? Again, time will tell with that. Looking still at wounds and other aspects, variations, this was a study that looked at surgical wound dressings and the incidence of surgical site infections in dogs undergoing a TPLO. Basically, they used tissue glue and an adhesive barrier, a special dressing, post-TPLO. They had 440 dogs, and they basically either had no dressing, they had the tissue glue, or they had this adhesive barrier dressing. And they examined them 14, 30, 60, and 90 days post-op. Risk of surgical site infection overall is about 2.3%, which is pretty consistent with what we talk about in the literature. And interestingly enough, really the only significant factor in dogs that had an incisional infection was that they were overweight. There was really not any difference in how the incision was cared for after the surgery. So I thought it was kind of more interesting we always talk about weight management, increased weight being an issue with a lot of these, especially orthopedic patients, and so they showed that certainly can increase the risk of incisional infections post-operatively. Always things out there about hyperbaric oxygen therapy that kind of circles around and around, but it still has yet, I think, to completely grab hold. So this was a prospective evaluation of hyperbaric oxygen therapy for wound healing in dogs, and kind of looking at chronic wound model. They had the effect of hyperbaric oxygen on acute surgically created wounds and incisions. So they made 2 by 2 centimeter wounds and 2 3 centimeter long dermal incisions created on the dorsum of 10 dogs, and these dogs either got hyperbaric oxygen once a day for 7 days or nothing. And they measured, they did histopathology on the biopsy site, on the incision sites, looked at contraction and epithelialization, the size of the wound, and just subjective evaluation. Again, I think varying clinics this seems to be more prevalent just because I think there are a lot of companies out there that try and say, hey, you want to try our oxygen chamber for a while and see how it works. But basically they put the dog in the oxygen, and you see they're kind of watching it over there, and the treatment regimens, I think, will vary depending on what they're using them for. There are other applications besides wounds that people are looking at for sure. Basically, the thought is that the hyperbaric oxygen will cause hyperoxygenation of the tissue, result in vasoconstriction, downregulation of inflammatory cytokines, upregulation of growth factors, antibacterial effects, potentiation of antibiotics, and positive leukocyte effects, all helping to promote wound healing, which is the thought. Maybe in acute, well-perfused wounds, it might not be as necessary, but maybe more chronic wounds where we want to kind of really jumpstart that process, it may be helpful, or that is what this study was looking at. And really they didn't find any difference in any measure at any time period. So it was tolerated with no adverse effects, but the question still remains, is this really a beneficial tool? Is this worth having this chamber in our clinic? At this point, I would say not necessarily. Moving on, touching a little bit, a couple of talks about brachycephalic anesthesia. Obviously, always not fun to have to deal with some of these guys and have to anesthetize them. Whether or not we're anesthetizing for brachycephalic surgery, anesthetizing a brachycephalic patient is just not always fun. So this looked at the risk of perianesthetic complications in brachycephalic dogs. Do they really carry a greater risk? We kind of subjectively think they probably do, but do they really carry a greater risk of morbidity with anesthesia? And so this study looked at brachycephalic, and they matched them with non-brachycephalic dogs. They looked a little bit at matching age and weight and sex, but really we're looking at more of the type of procedure they were undergoing. So, for every spay that a brachycephalic had, they had a non-brachycephalic. For every orthopedic surgery, they matched the two of them together to look at those and their recovery. They had 446 dogs in between January and December of 2012. And basically there was a 49.4% prevalence of overall anesthetic complications. They didn't really break it down into what types of complications, but they looked at 8.7% prevalence of post-anesthetic complications, which is obviously where a lot of times we're most concerned during the recovery period. And 13.9% of those were brachycephalic dogs, 3.6% of the non-brachycephalic dogs. So there was definitely a significant difference that the brachycephalic dogs had more post-anesthetic complications than the non-brachycephalic dogs. The other factors that increased the risk for perianesthetic complications was increased ASA status, the invasiveness of the procedure. More invasive procedure did carry a higher anesthetic risk, use of ketamine Valium for induction versus propofol, and then just a longer anesthetic duration. So those were some other factors that did have an effect on anesthetic complications, but certainly being brachycephalic was not. And this was a retrospective study, so there's always a little limitation with that. When I have a brachycephalic dog, and kind of the general tenets are, whenever we're dealing with anesthesia, I've seen, we've all seen them, I'm sure, they look very fine and stable, but as soon as we start getting them stressed, and they can go downhill pretty quickly. So always be prepared to intubate them, be ready, and having a variety of ET tube sizes is important. Obviously, some of these guys have hypoplastic tracheas, and we may not be able to fit the size we think, so kind of be ready for anything. Allow ample time post-operatively to monitor. These aren't cases we want to do at the end of the day and then let them hang out, because sometimes they need to actually stay overnight. We need to be able to make sure that they're fully recovered and ready to go home. Don't leave them unattended. And I'm always an advocate of trying to try not to let them get too stressed, which for me, a lot of times post-operatively, as long as they're stable, I'm always an advocate of trying to get them home as soon as possible, just because they're going to be a lot more comfortable there, obviously within means for stability. One talk looked at this little device. So this is actually a CPAP device. It's a little hood. It has a little seal on it that kind of goes around the patient. Now, arguably, is this going to stress them out? I guess this dog doesn't seem too bothered by it in this still photo, but it provides positive ventilatory support. It actually applies positive pressure to the upper airway. So this little helmet, and you can dial in how much pressure you want, and it just kind of basically helps them breathe after it creates a seal. And so they do say you're looking to get a pressure of 5 to 15 centimeters of water, depending on what oxygen flow you want. And and these guys report that it's actually pretty well tolerated in lightly sedated patients. So these may be the ones that you may need to be sedating them slightly anyway if they're having a rough recovery, and then this additional support. And I think there are some variations of these out there, but I just thought it was kind of interesting that just to help that post-operative window, which is really the most critical, may be a good support for them. Other one that kind of not specific to brachycephalics, the study anyway, but I think it has is relevant to our discussion on brachycephalics, is a look at postoperative gastroesophageal reflux after premedication with metoclopramide and Cerenia in 93 dogs. And this was a prospective, randomized, controlled clinical study. And so dogs either got the control or Cerenia and a metoclopramide CRI. They did not do a loading dose of Reglan. And they had 93 client-owned dogs, and they were measuring their esophageal, kind of more upper reflux potential with the pH meter, and looking for the evidence of reflux. If they, did that change, giving them Cerenia and metoclopramide, did that change their level of reflux? They found that 14% of patients overall developed postoperative reflux. There were no significant differences between the groups, the control versus the Cerenia metoclopramide groups. What they did find that could increase the risk factors for developing of these 14 dogs was if they were having gastrointestinal surgery, again, if they were overweight, body condition score over 3 out of 5, and if they needed to be sedated with Domitor after surgery, so they got really stressed out, anxious, and then had to be sedated. That was also an indicator. So those three things, not the medications alone, unfortunately, but those three things were a factor in whether or not these guys developed upper esophageal reflux. They weren't able to do the lower esophageal reflux study, so that is one negative of the study. They weren't able to monitor the lower esophageal reflux. And there was a question as to, since they didn't do a loading dose of Reglan, did that make a difference or not? I kind of just picked some abstracts that couldn't necessarily group together in one big topic, so these are just kind of some miscellaneous random abstracts to talk about some things. There was a talk that looked at, an abstract that was presented that looked at canine spontaneous hemoperitoneum or hematoabdomen, and looking at the source, i.e. liver, spleen, etc., in relation to body weight. And so, you kind of think about small dogs, little dogs, German Shepherd, Golden Retriever walks in with a hemoabdomen, your mind's going to go to splenic tumor. A little dog, walks in and it might be, it's not as intuitive that it might have just splenic mass. And so most of the data that we have on hemoabdomen and splenic masses is from large dogs, because that's more common population. So the study looked at 637 dogs with spontaneous hemoperitoneum that were surgically and non-surgically addressed. And they looked at the relative risks of the sources and the etiologies that were estimated. They found that splenic hemorrhage by far occurred in 43% of small dogs and 61% of large dogs. Small dogs did tend to have a 30% reduced risk of having a hemoabdomen that was the result of a splenic mass or splenic bleed. They did have increased risk of having a bleed that was either from the liver, 80% increased risk of hepatic hemorrhage, a 212% increased risk of retroperitoneal mass hemorrhage, and 156% increased risk of hemorrhage from sources other than the liver, spleen, or retroperitoneum, which, not that, I mean, then you're probably talking kind of omentum, or, metastasis of nodules, things like that. All the dogs, so certainly the splenic mass is more likely in the larger dogs than little dogs. All surgically treated dogs were significantly younger and more likely to have splenic. And we go through this process when we see a dog on emergency. Owners go through a lot of this decision-making process as to whether to do surgery. Certainly their age is probably going to play a role. We typically are going to do ultrasounds on these guys and look for the evidence of liver metastasis in conjunction with a splenic mass. And those dogs we often don't go to surgery, or usually don't go to surgery on. So it makes sense that the ones that had surgery we already know are probably more likely to have a better chance. Hemangiosarcoma as a specific diagnosis also occurred less commonly in small dogs, 57%, versus large dogs, 78% of those that had the spontaneous hemoperitoneum. Kind of putting numbers to probably what we kind of intuitively think about clinically. Also when we're talking with owners, it kind of help guide our discussions a little bit in terms of prognosis and recommendations. Assessment of body condition composition in dogs with cranial cruciate ligament rupture. They had 24 client-owned dogs with cruciate rupture and then matched them to 24 without cruciate rupture. And they assessed their body composition by basic measures of body weight, body condition score, but they also used a DEXA scan. And I'm more familiar with using it for looking at bone density, but dual energy X-ray absorptiometry can also provide measurements of total body mass, bone mineral content, and bone mineral density, as we're most familiar with, but also lean soft tissue mass and overall body fat. And so this is, they've got a little legend here, purple is lean and yellow is fat. So you see this dog has a lot more body fat than this dog, and so it may help. This was what they looked at in these dogs that had cruciate disease and that didn't have cruciate disease. Pretty straightforward, pretty simple. And basically, they're still kind of presenting their preliminary results, which found that the body condition score and body weight, the objective numbers, were significantly higher in the cruciate group. And the cruciate group also had a significantly higher body fat percentage, lower bone mineral content percentage, and lower lean mass percentage based on the DEXA scan results versus the non-cruciate group. Now, arguably, and they brought up the point, is this a cause of cruciate disease, or is this a consequence of cruciate disease? That that's one of those things. Cruciate disease is always hard to study because we don't know when it occurred and cause or effects, things like that. But certainly, even if nothing else from a surgical standpoint, when I talk to owners about surgery and the overall outcome, we do talk about body weight being certainly a significant factor in their recovery as well. So kind of intuitive, but again, putting numbers to what we kind of already think and know. Stifle osteoarthritis at the time of diagnosis of cranial cruciate ligament injury is, they spelled it out here in the title, more severe in boxers compared to other dog breeds, and is most severe in the proximal, lateral, and caudal aspects of the joint across breeds. So basically they looked at the severity of stifle OA radiographically, and characterize its distribution within the joint. When we look at an X-ray, we're looking at the patella, the caudal compartment, etc. They specifically looked at boxers, German Shepherd dogs, labs, and huskies. Basically, they had 240 stifles from those dogs with confirmed cruciate disease. And they found that the OA score was higher in boxers specifically than those other four breeds, and in dogs greater than 35 kilograms. More specifically, it was highest in the proximal, lateral, and caudal aspects of the stifle. Again, cruciate disease being tough to study, the chronicity prior to diagnosis was not assessed. So, how long did that have a factor in the overall results is a little hard to know. But certainly there can be maybe a breed-specific score, and certainly the bigger dogs also a factor. And this went a little faster than I was expecting. So those are the abstracts that I have that I've presented. The references that follow, I kind of just, those go through the course of the talk, so each slide is, kind of in order from where it was presented in the talk. The abstracts themselves are their own reference, but then the little reviews and things like that are kind of scattered throughout in support of each of these topics. So that's all I have. Are there any questions or thoughts or other things that we want to talk about?
Explain the tumors and all. What's the recommendation to the owner of possible metastasis showing up seeding and so forth?
Well, we definitely recommend doing 3-view chest rods and abdominal ultrasound. And basically we're looking for, we see a mass, confirm a mass in the spleen and don't see evidence of metastasis in the liver. And we recommend going through, for surgery. And I always talk to clients, if it happens during the daytime and Dr. Vansel is around, we often try and have them have a discussion with the oncologist before, just so they can have that overall information, because certainly the likelihood is it's going to be hemangiosarcoma, even still. And if they want to move forward, certainly the benefit, the way I usually present it is, our one goal is to just get them through the crisis. Big disease picture aside, if we can get them through the crisis, that's going to be helpful, and then we can worry about the disease process as well. I will say I have found that ultrasound is not always perfect, and we definitely get in sometimes and find that there are mets in the liver even when the ultrasound did not detect them. And sometimes we have conversations with the owners during surgery and they stop. Sometimes we just say, well, we at least removed the active bleeding spleen, and these liver mets or at some point may start bleeding, but it's really not feasible to remove them all. Sometimes we've kind of gotten out of the habit of doing echoes to look for heart-based tumors. Sometimes we'll do that too. Sometimes the owner still wants to do that. But it depends a little bit on the owner, but I think if nothing else, getting through the crisis, can definitely be enough. A lot of them just want to do that, get them through the crisis, the bleeding crisis.
So does Tramadol have a place in practice still?
We stopped using it. We have some people, and we still find some of the doctors will put them on like gabapentin and Tramadol, but I question whether it's really necessary. I think we found that we were, especially in some of these big orthopedic cases, sending them home with just so much Tramadol. A big dog that gets 4 tablets every 8 hours is just a lot. And if there's more evidence that it's not being as effective, and since it's probably been about maybe a couple months since we've really been kind of making the switch, we felt that it's been the gabapentin has been working. Now, having used Tramadol for a long time, I felt anecdotally it seems like it's been effective. I haven't really felt that my patients haven't been taken care of, so I guess maybe I don't think we have enough proof to say let's definitely get rid of it, but I think we're maybe heading in that direction, and there are other medications that are coming in that may be a better alternative and more substantiated.
I know the orthopedists at UT have been kind of big on Tylenol.
Mm-hmm.
Do y'all use?
We don't, but I have heard. I do hear that a lot. And some of you guys might remember Dr. Hendricks, PK Hendricks, who was our anesthesiologist, who was here for a little bit. She has also been. I think if she were still here, she would be pushing us also away from the Tramadol, and I think they've been using that. But we haven't. It's more, I think it just becomes kind of what people just do, and rather than starting something else.
Do you use many joint supplements such as the Adicorn or Tosacorn or Dasacorn or stem cell even?
We don't use them here. It doesn't mean I don't advocate them. I think for our purposes, where most of the patients we're seeing are post-surgical, we see them for suture removal and then we're usually not doing long-term management, I definitely highly recommend using them. But usually I expect that they'll probably come back to you guys for the, long-term management of arthritis and things like that. So we don't carry those here, but I definitely feel that Adequan and the conjoint sulfate supplements are beneficial to use in arthritic patients. The stem cell, when I was out in San Diego, the company that the vet stem that does the harvest, one of the first ones that harvests from the fat, they're out there, and so I got a little bit of use of that out there. And I know they are looking at it from the bone marrow. That's another one of those that there's some kind of peripheral things, but it's still not really been a true hit in how well it works. I will say the couple of cases I've used, I feel that maybe there has been some effect, but it's temporary. It's not a long-term effect. The company out in California, they harvest the stem cells, and they'll, for an additional charge, they'll freeze some back, and so if they want another dose, they can send them to you. So I think there could be some benefit, and I think there's show that it does have some anti-inflammatory effects. I think it's just not necessarily as practical because it does require, at the minimum, a bone marrow aspirate or surgery to harvest the fat. So I think that's why it hasn't really caught on as much. And again, it hasn't been proven as much out there. I always talk to people too, acupuncture, physical therapy. The physical therapy for sure is growing, and as that's becoming more available, I think that can definitely be of benefit too.
Do you have an opinion on therapy laser post-op or? I will say we're with our rehab group here. We're doing a lot of our post-surgical patients that haven't gotten, as long as they haven't gotten surgery for neoplastic disease, they're getting their incisions lasered. Now, we've not been very good about, kind of actually objectively looking and seeing what kind of the benefits of that would be. I certainly doesn't hurt. Again, I think some of the, really hard-hitting literature is not out there necessarily that supports its use.
If you ever used any of the cannabis, I know you talked about it, but have you used any here?
We haven't. We get, Dr. Vansel, I think, gets a lot more questions about it probably for the neoplasia disease, but we don't have it here. I think it's pretty expensive, isn't it? And I think that makes it a little cost prohibitive. We definitely get clients asking about it. And I did have one client who, I forget even what we had done the surgery on, but somehow she got some from Canada but we don't have any information really about how much, what kind of dosing and things like that. And I would say with this abstract talking about the liver enzymes, I hadn't really ever heard that or appreciated that. That's certainly something that's kind of makes you a little nervous about, chronic use, especially when we're not really sure what the doses are, what we should be using. It seems like there's just so many little factors from that plant that, which one are we really wanting to use, and are they isolating it appropriately and things like that. It seems like a potential positive, potential negatives.
I have a one management question.
Mm-hmm.
I was talking to a plastic surgeon this week. He was using nitro paste.
Nitro paste.
For incisions.
Huh.
Post-op. And I was like, well, that's kind of makes sense.
Yeah.
I don't know if it would be anything.
I hadn't heard of that, but I think, was it like for scar tissue formation, or was it?
Maybe more for scar tissue.
Yeah.
Just trying to dilate vessels.
Yeah.
Just post-incision closing and whatnot. So the wheels were turning as far as wound management goes.
Yeah. Yeah, no, that's interesting. I will say we get into sometimes too a lot of the human versus canine skin. Their skin's so different. The vascularity is actually pretty different. We went through a phase where we were using the lidocaine patches. I don't know if any of you remember those, where they, basically we'd cut the lidocaine patch into a bazillion little strips and line it up around the incision, and it never really felt like it was doing that much. And I think it wasn't getting absorbed quite the same way that it does in people.
Along those same lines, splash block with lidocaine, is there anything to that?
I used to do actual incisional block, the injection. I think there can be something to that for short term, for sure. It's kind of not a routine thing. I think some people probably do it regularly, and I think it can be effective. And I know they have been talking recently about, we used to do the whole bupivacaine and lidocaine, bicarb, and all that kind of stuff, but I think they're looking at now that mixing the bupivacaine and lidocaine together will actually maybe interfere with their function together. So not mixing them together may be better.
What about cats?
Yeah, that's always a good question. I always feel bad for the cats because they just don't get the research they need. I mean, I will say, and I've used the gabapentin for this is kind of an aside, the sedative, the calming effects, and I think that actually, I have like one but I think that worked actually really well. And we use gabapentin in cats for pain control. I mean, we still have meloxicam. I mean, I used to use meloxicam a lot in cats before they actually black labeled it and felt that it was pretty effective. I know they use it in Europe a lot in cats, but you feel like you have to be so careful these days, about doing something that's not kosher. We've got the Ensure here, for the 3-day pack, and that seems to be effective. I always loved, if you can use an NSAID, I mean, that's always going to be my ideal, just because you're going to have the inflammation. But yeah, cats always get the short end of the stick for sure. And they're hard to assess anyway. They're so good at hiding. I know they've done some. I remember there was an abstract that came out, I don't remember exactly when, but they looked at cats that had cats that had died natural causes, and they just kind of went back and just x-rayed a bunch of them, and they found, a high percentage of them had arthritis, and no one ever knew. We always talk about dogs not really getting arthritis unless there's an underlying reason, like they have a cruciate rupture or they have a hip dysplasia, but cats, they get arthritis and they hide it very well. All right. Thank you. Have a good night.